Good afternoon. Today I will be presenting on acute intoxication among children in Monrovia, Liberia. In July 2015, at MSF Hospital, we witnessed an increased admission of children with respiratory distress, hepatomegaly, hypoglycemia, and more importantly, absence of fever, which was considered by the clinicians as unusual, suggesting a toxicological etiology rather than an infectious one. Children reported taking paracetamol, anti-malarial drugs, antibiotics, and traditional treatments. This had led the clinicians to hypothesize that the traditional treatment is behind this toxicity. Therefore, the objectives of the study is to describe the toxidrome and to identify the toxicant. In order to meet our objectives, we divided the study into two parts: a case series particular to the toxidrome and a case control to be able to identify the toxicant. The case series includes all suspected patients that have been admitted to MSF Hospital between July and December 2015. The children are eligible to be enrolled in this study if they present two different organ symptoms that cannot be explained by any infectious or non-infectious condition. In addition to that, we collected blood plasma and urine to be able to test for the level of the toxicant in the body. In total, we got 77 cases from July to December 2015. This graph shows the fluctuation of the number of cases and death over the study period from week 28 till week 52. Almost 2/3 of the patients were under the age of 1 year old. 45.5% were dead during hospitalizations, and 2 were discharged against medical advice. The most common symptom was respiratory distress, followed by hepatomegaly and hypoglycemia. Liver enzymes were also an important indicator, where we see AST and ALT were elevated among the majority of the patients. Severe elevation of both enzymes was noted among 50% of these patients. On the other hand, ALP was mildly elevated among 27% of the patients, and this elevation was less than 2-fold the normal range. We managed to test PT and INR among 4 patients only. The results were found to be severely elevated above the normal range. Toxicology indicators include AST-ALT ratio, elevated anion gap, and severe decrease in total carbon dioxide were prevalent among the study participants. Elevated anion gap and total carbon dioxide, they were the only predictors that associated significantly with death, marking the final stage of the condition. On the other hand, medications applied and treatments applied in the hospital did not statistically associate with preventing death as an outcome. Moving from the case study to the case control study is a pairwise matched monocentric case control targeting children under 5 years old that are admitted to MSF Hospital and residing in Greater Monrovia. In order to reach a power of 80%, we needed 30 cases and 60 controls. Out of the 77 patients that were enrolled in the case series, we managed to select 30 cases that have similar medical profiles following a more specific case definition. The case definition includes respiratory distress, normal saturation of arterial, okay, it's not gonna come out. Liver dysfunction, arterial oxygen, liver dysfunction, in addition to one of the following: absence of fever or hepatomegaly or hypoglycemia. For the control to be eligible for this study, they should not meet the case definition, and they need to present a non-trauma related illness. This might make our matching criteria a bit stringent. Therefore, we decided to match for the 30 cases, 60 hospital and 60 community controls. The matching criteria includes age group and sex for both control groups. As for the hospital controls to be able to match with their respective cases, they need to be admitted in the same month of admission and having the same triage results. On the other hand, community controls need to present their illness in the same month as the case and reside in proximity of their respective cases. Finally, we matched for the 30 cases, 53 hospital and 48 community controls. Anion gap, altered consciousness, difficulty breathing, vomiting, and convulsions associated significantly with the condition presented at a higher rates among the cases than among the controls. The suspected toxicants included conventional medicine and traditional treatment. Paracetamol was the most prevalent to be reported among both the cases and the control. However, paracetamol supratherapeutic doses were also present at a different rates between the cases and the control. For example, the paracetamol supratherapeutic dose was 60% among the cases and 21% among the hospital controls. And by paracetamol supratherapeutic dose, we mean the consumption of 200 milligram of paracetamol per 1 kilogram body weight in 24 hours, or 150 milligram per kilogram body weight in 48 hours, or 100 milligram per kilogram body weight in more than 48 hours. Antibiotics and antimalarial drugs, they were prevalent among all the study participants, however, at higher rates among the community controls than their counterparts. And that is due because these sought healthcare at the pharmacy or stashed medication at home. Total traditional treatment was slightly higher among the cases than the controls, and notably, pre-prepared bottles were among four different patients, 3 cases and 1 control. By pre-prepared bottles, it's a type of traditional treatment prepared of a mixture of herbs and unknown substances manufactured by allegedly traditional healers and sold in the market. We ran the multivariate analysis with 3 main exposure variables of paracetamol high dose consumption. The 3 variables, as we see in the table, paracetamol supratherapeutic dose, paracetamol more than 500 milligram per day, and paracetamol more than 1,000 milligram per day were the exposure variables. They all associated significantly with the toxicity at higher odds of developing the conditions. Traditional treatment was not significant in any of the models applied, and pre-prepared bottles were significant, associated significantly with a condition in 2 models. That's precisely the paracetamol more than 500 milligram and paracetamol more than 1,000 milligram per day. The study had the following limitations. First, possible reluctance in reporting certain medications or doses, and particularly traditional treatment. Many medications and doses were unknown due to the lack of the knowledge of the parents, or even unavailability of the medicine itself. At the level of the hospital, there were some laboratory tests that were essential but unavailable. We can name lactate, PT, INR, which are usually used as liver function tests. Toxicology labs needed to identify the toxicant and test for the level of the toxicant in the body are unavailable in Liberia. Therefore, we needed to transport the biological specimens to France. This has delayed the results many, many months. Actually, as a matter of fact, the specimens have arrived to France this week, but we still do not have the results yet. At the level of the community controls, some information were unavailable, for example, the weight of children and laboratory tests. And finally, the sample size for the controls was not reached. Electrolyte imbalance, elevated anion gap, and the severe elevation of liver enzymes, precisely AST and ALT, highlight an intrinsic hepatocellular injury, which is usually accompanied with paracetamol toxicity. The biologic plausibility with a strong statistical association between paracetamol and the condition, we have concluded that the primary suspected toxicant is paracetamol. Literature suggests that paracetamol intoxication is an underobserved problem in the developed countries, and of course in developing countries where research and laboratory is still very limited. Laboratory technology is still limited. Treatment procedures at the level of the hospital were ineffective. Therefore, faster procedures for sample transportation are required to be able to identify this toxicant and test its levels in the blood. Consequently, we will be able to adapt our diagnostic algorithms and the treatment protocols, taking into consideration that up to date, we are still having the influx of these cases. It still continues till today. Thank you very much for your attention.
Many thanks, Mohammed.